Now we are going to explain one of the most clinically important drugs. This conversation, and especially the second half of it, will be a bit more clinical rather than oriented to basic pharmacology. So to start, beta blockers are acebutolol, atenolol, bisoprolol, carvedilol, celiprolol, esmolol, labetalol, metoprolol, nebivolol, etc. It may seem a lot, but actually it's very easy to remember the names. First of all, they have similar ending, olol. Some of them have a bit modified ending, alol or ilol, and they have additional function. We have rules to remember them, which makes everything very easy. Beta blockers are divided according to their affinity toward receptors. Beta-1 selective blockers, also known as cardioselective beta blockers, have more affinity towards beta-1 rather than beta-2 receptors. For example, acebutolol, atenolol, bisoprolol, esmolol, and metoprolol. Their names follow alphabetical order from A to M. Non-selective beta blockers block beta-1 and beta-2 receptors equally. For example, nadolol, pindolol, propranolol, timolol. Their names are between N to Z. And non-selective alpha and beta blockers, also known as mixed blockers, block alpha-adrenergic receptors as well as beta-1 and beta-2 receptors equally. For example, carvedilol and labetalol. They have different ending. Instead of olol, they end on ilol and alol. I always tell students to write labetalol like this. Write alpha and beta, labetalol. It contains alpha and beta in its name, and it will help you to remember the receptors that labetalol block. There is new beta-1 selective blocker with ability to activate beta-3 receptors in the heart and in the blood vessels and release nitric oxide from vascular endothelium, causing vasodilation and decrease in systemic vascular resistance. This effect improves peripheral perfusion. Nebivolol is the most cardioselective beta blocker that we have. You can remember it by writing new beta-1 and olol, and there is nitric oxide or NO in the name, which is released from the endothelium. Hope it helps in remembering. Sotalol has also a different ending. It's not only non-selective beta blocker but also potassium channel blocker, which makes it a potent antiarrhythmic drug. I'll explain this in details when I cover antiarrhythmics. All of these drugs are antagonists of beta receptors, and pindolol and acebutolol are partial agonists. You can remember by words, partial agonist. Pindolol and acebutolol start on same letters. Being partial agonist means having intrinsic sympathomimetic activity. They block receptor and even have small effect on its activation. They have less bradycardia in contrast to true beta blockers. So remembering their names and mechanism of action is very easy if you just remember this alphabetical rule. It has huge clinical importance. Another thing is that cardioselectivity is dose issue. When you increase the dose, beta-1 selectivity disappears. For example, bisoprolol has 120 times higher affinity toward beta-1 receptors rather than beta-2. But in high dose, this selectivity will be lost and it will block both beta-1 and beta-2 receptors. We use beta blockers quite often in our clinical practice, and they are particularly important in cardiovascular disorders. They have prominent effect on the heart. Beta blockers decrease heart rate and myocardial oxygen demand. They prolong diastolic phase and coronary diastolic perfusion time. They prolong filling of the ventricle and reduce myocardial oxidative stress. Beta blockers decrease cardiac remodeling and protect heart from arrhythmias. This is particularly true regarding carvedilol, bisoprolol, and metoprolol in case of heart failure. They decrease mortality and increase survival in cardiovascular disorders. Decreased cardiovascular mortality means that the patients with cardiovascular disease who take beta blocker live longer than those who do not take beta blockers. Beta blockers have antihypertensive effects. They decrease cardiac output and decrease renin release from the kidney. However, antihypertensive effects are mainly mediated by decrease in cardiac output rather than decrease in renin release. Carvedilol has more blood pressure lowering effect when added this drug to the chronic antihypertensive regimen because it blocks alpha-1 receptors and decreases systemic vascular resistance. We can use esmolol and labetalol in case of hypertensive emergency. Esmolol has shortest half-life, 9 minutes, and is suitable for a rapid offset when treatment is no longer necessary. You can remember this by writing its name, A-small-o. Labetalol is alpha and beta blocker, and this drug is one of the few safe drugs in pregnancy. It can be used in case of aortic dissection as a first-line agent to lower blood pressure. We can use beta blockers as heart rate control and as antiarrhythmics as well. Sotalol has ability to block potassium channels on the myocardium and is considered as class 3 antiarrhythmic drug. In case of cirrhosis, non-selective beta blockers such as propranolol and nadolol can decrease portal pressure and decrease risk of varicose bleeding. Timolol decreases aqueous humor production and decreases intraocular pressure, which is beneficial in glaucoma treatment. Besides this, timolol along with propranolol and metoprolol can prevent migraine attacks. Due to its lipophilicity, propranolol can enter in the CNS and has calming effect. It can decrease anxiety and phobias. This can be particularly helpful in performance anxiety, for example, for musicians, for politicians, and so on, generally for people who are afraid of public speaking. Propranolol and atenolol block adrenoreceptors in the muscle spindles and can decrease tremor. Propranolol is drug of choice in essential tremor. It's non-selective beta blocker, but when beta-1 selective blocker is required, atenolol can be used instead, but to be honest, it's less effective. Infantile hemangiomas are most common vascular tumors in infancy. Propranolol can reduce their volume, color, and size. In peripheral tissue, thyroid hormone T4 is converted to more active form T3. This conversion is happening by peripheral enzyme 5-deiodinase. In hyperthyroidism, especially in thyroid storm, we can give medications to decrease this conversion. Propranolol can inhibit 5-deiodinase and decrease this conversion. Besides, it will decrease heart rate accompanied in hyperthyroidism. Metoprolol also has ability to inhibit 5-deiodinase, but its effect is relatively small. And finally, there is genetic disorder, Ehlers-Danlos syndrome. It's connective tissue disease, a disorder of collagen formation, characterized by skin hyperextensibility, joint hypermobility, and tissue fragility. Vascular Ehlers-Danlos syndrome is the most severe form because of its ability to cause life-threatening vascular complications. The most important complication is aortic aneurysm and aortic dissection. Celiprolol is a unique beta blocker with the ability to block beta-1 and activate beta-2 receptors. This unique mechanism, particularly activation of the beta-2 receptor, may induce bronchodilation. It acts as a vasodilator, decreasing the pressure loading on the aorta and inhibits further aortic dilation. In this year, 2024, European Society of Cardiology released guidelines for the management of peripheral arterial and aortic disease and recommends to consider prescribing celiprolol in case of vascular Ehlers-Danlos syndrome. However, this drug is not FDA approved. For most disorders, beta-1 selective drugs are more likely to be prescribed. Lungs, peripheral blood vessels, endocrine system, and central nervous system can be negatively affected by beta blockers. Blockade of beta-2 receptors leads to bronchospasm. Remember, beta-2 is dilatory receptor, and as I already told you, a selectivity is a dose issue. In high dose, beta blockers lose selectivity. It makes beta blockers contraindicated in asthma. Beta blockers cause bronchospasm and resistance to the effects of inhaled beta agonists used as a treatment of the asthma. Even topical, ophthalmologic non-selective beta blockers can cause exacerbation of the asthma, but patients with COPD can take beta-selective blockers. I want you to know that all beta blockers are contraindicated in decompensated bronchospastic disease. The peripheral perfusion is mediated by beta-2 receptors. Non-selective beta blockers can exacerbate peripheral artery disease and trigger Raynaud's phenomenon. Beta-2 stimulation dilates large coronary arteries, whereas parasympathetic stimulation dilates only small coronary arteries. Therefore, non-selective beta blockers should be avoided in vasospastic angina, also known as Prince-Metal angina. Beta blockers have negative chronotropic effect. Beta receptors are located in the cardiac conductive system and in the myocardium. Beta blockers decrease heart rate by decreasing pacemaker activity and have potential causing AV block. Physiologically, epinephrine has important effect on glucose metabolism. These effects are mediated by beta receptors. Epinephrine stimulates glycogenolysis and gluconeogenesis from glycerol and pyruvate. All these effects are protective against hypoglycemia. Beta blockers can exacerbate hypoglycemia and mask its adrenergic effects. If you ever seen a patient with hypoglycemia, they have sympathetic symptoms like tachycardia, tremor, irritability, anxiety, sweating, etc. Beta blockers block these effects and make it extremely difficult to recognize hypoglycemia unless you measure blood glucose. Bisoprolol has no effect on blood glucose, but it can still mask the manifestation of the hypoglycemia. Another endocrine effect is worsening insulin resistance in type 2 diabetes mellitus. Normally, alpha receptor leads to vasoconstriction, decrease in perfusion, and decrease in glucose uptake in skeletal muscle. This leads to hyperglycemia, which further stimulates insulin release. Beta-2 receptor has opposite effect. In case of beta blocker treatment, beta-2 receptor is blocked and alpha-1 effects are unopposed. This decrease lipolysis in adipocytes, leads to weight gain and worsening glucose tolerance in type 2 diabetes mellitus. Beta blockers also reduce energy expenditure, which can further worsen weight gain. According to clinical studies, mean increase in body weight is approximately 1.2 kilograms. Chronic use is associated with dyslipidemia, increase in VLDL, and decrease in HDL, so-called good cholesterol. However, newer beta blockers such as bisoprolol, carvedilol, metoprolol, and nebivolol have no metabolic adverse effects. They are exactly same drugs that increase survival and decrease mortality in myocardial infarction and heart failure. Historically, it was known that beta blockers are associated with depression, fatigue, and erectile dysfunction. Honestly speaking, there is no significant risk for such side effects, and let me show you why. At the beginning, there is sexual arousal, mediated by catecholamines and sympathetic stimulation of the beta-1 receptor. After arousal, there is erection, which is parasympathetic and mediated by the nitric oxide-induced vasodilation. Emission is sympathetic response and is caused by contraction of vas deferens and ampulla. And ejaculation is expelling of the semen from the penis and is sympathetic response, mediated by the somatic nerves and by alpha-1 receptor. Number one cause of erectile dysfunction is psychological. Theoretically, beta-1 blockers could decrease arousal, but this effect may be more associated with knowledge about the side effect and anxiety rather than the drug itself. However, alpha blockers are indeed associated with sexual side effects. As emission and ejaculation are mediated by the alpha-1 receptors, alpha-1A blockers such as tamsulosin are associated with the abnormal ejaculation, including ejaculation failure and retrograde ejaculation. We prescribe and stop beta blockers gradually by up or down titration of the dose. There are initial and target dose. We always start with a low dose and increase dose gradually, ideally in 1 or 2 weeks. For example, we have 25 mg of metoprolol here. Next dose will be 50, then 75, 100, 125, 150 mg, and so on until we reach a target dose, or side effects appear and patient cannot tolerate the further dose increase. We call this maximally tolerated beta blocker dose. The stopping or deprescription must also be gradual. If one requires stopping the drug, you must not stop suddenly. You have to start the prescription gradually. For example, if 150 mg is prescribed, step down to 125 mg, then 100, then 75, and so on, until last dose is taken, and only after that you can stop. You do so to avoid beta blocker withdrawal. Sudden withdrawal of beta blockers can lead to tachycardia, exacerbation of the ischemic symptoms, and even triggering the myocardial infarction in patients with a known coronary artery disease. Precipitated arrhythmia can be severe, for example ventricular tachycardia and ventricular fibrillation, leading to sudden cardiac death. The mechanism of this effect involves upregulation of the beta receptors during the treatment. This is so important that if the patient chronically takes beta blockers and presents to us with, for example, acute decompensated heart failure, we do not stop beta blocker, but only decrease the dose in order to avoid sudden withdrawal, which will cause significant increase in heart rate and worsening the condition.